Good morning and welcome to GP Video Podcast by Nadia, episode 12, part 2. So if you guys remember, yesterday we were talking about premenstrual dysphoric disorder, PMDD. Before that, I told you about PMS, which is premenstrual syndrome, which I told you that 80% of women of menstruating age, of reproductive age, experience, which 80%. So 80% is like a big number. And what happens is just 1 week before menstruating or bleeding, women start feeling like they are bloated, they are irritable, they are fatigued, they are generally not feeling well. But like all in the category of minor symptoms, or if they have they suffer from migraine, then they have increased frequency of migraine and severity of migraine, or otherwise they will get low grade headaches. So these are all the constellation of minor physical symptoms that 80% of women of menstruating age experience 1 week or 10 days before menstruation. Then we spoke about a more serious and a severe condition called PMDD, premenstrual dysphoric disorder, which 10 to 15% of women suffer from, of reproductive age, or of the age in which females menstruate. Now, how do we differentiate? I told you that PMDD. So first of all, I would like to clear a confusion here, which Professor Jayashri Kulkarni also mentioned in her podcast, is that there is a general assumption that women have 28 days cycle, like regular cycles, in which the first 7 days they bleed and then 21 days are the normal days. But that is not true. This is textbook. Yes, something of that sort every woman has, but it's not always regular, and it's not always 28 days. It's not always 7 days of bleeding. So basically, the definition of PMDD is that all the symptoms of PMDD, which is premenstrual dysphoric disorder, ideally, according to the textbook, should occur 7 to 10 days before starting bleeding. So in the last 7 to 10 days of the cycle. But because all women don't have textbook cycles, so it can happen anytime during the cycle. So any 7 to 10 days of the entire cycle, when you have sudden onset of starting off with rage, you're very angry, then feeling sad, feeling suicidal, having anxiety, having panic attacks. These like sudden onset of all of these symptoms which were not there before. And then after that, sudden offset. So once bleeding starts, or that cycle, phase goes, there is sudden offset. So people usually even they can clap their hands at you or snap their fingers to show the onset and offset of these symptoms. Along with that, you can have physical symptoms as well. You can have bloatedness, you can have GI upset, you can have irritability, but like these symptoms, the mental health symptoms are more severe. You are severely depressed. You're very sad. Before that, you're very enraged, very angry. And then after that, you can even be suicidal. You have panic attacks. You have brain fog. You cannot remember anything. You cannot multitask. You cannot perform your daily tasks, which you are doing on day-to-day basis. So these are all the symptoms of PMDD. Now, what is the etiology? So researchers have researched on this, and they have found a gene complex that is present in 50% of women with PMDD. And actually this gene complex, according to the studies, it remains dormant, it's not activated. But let's say after a traumatic event, it just gets activated. For example, a woman had a traumatic childbirth, and after that she starts having PMDD. So before she had the gene, but the gene was not expressed because there was no trauma before that. So, or women who have had any kind of abuse or assault during their reproductive years, anything traumatic, both physical and mental, can activate that gene complex, and then women will start having PMDD. So what is the treatment? Today I will start touching the treatment part, but I will continue with it tomorrow as well. Treatment, because it is hormonal, because it is hormones causing irritability, hormones causing depression, hormones causing anxiety, panic attacks, hormones causing PMDD, premenstrual dysphoric disorder. So the first line of treatment is hormones. Okay, so in hormones, we know that there are two female reproductive hormones, estrogen and progesterone. The mainstay of treatment, which is which has the neurocalming effect, is estrogen. So always remember, estrogen is the answer to PMDD. But because uterus, when you give women estrogen, the ones who have uterus and are bleeding, we need progesterone also to cover it, because what happens is when you give too much estrogen, we need to cover the lining of the uterus by progesterone. So we have to give both the hormones to the lady, but estrogen is actually the main part. Estrogen is the treating part. So we have to find, so there are so many, there are so many combined pills in the market, but we have to find a pill that has more of estrogen and less of progesterone. Also, progesterone should be the nice one, not the actual synthetic progesterone. The nice progesterone in small quantity and estrogen in big quantity, and the estrogen that can actually cross the blood-brain barrier. There are some estrogens that do not cross the blood-brain barrier, but we need the estrogen that crosses blood-brain barrier. And at the moment, what we have in market in Australia, I'm talking about, is something called Zoeli. So Zoeli is the combined hormonal contraception pill that we put women on. And for the first 3 cycles, you can actually even miss the inactive pills. You can just do 21 of the active pills, then go to the other packet, then go to the other packet. So again, as I said, I am crossing the limits of the time. So I'll come back. So I've already discussed with you that the first line of treatment is Zoeli, or the hormone pill, and we'll continue from here tomorrow. Thank you.